So after discussing different approaches, now we go towards different clinical conditions and the way to manage those conditions. The first we'll start with fevers. The fevers and to treat fevers has been a quest to many homeopaths and many of our friends and colleagues. And I have seen a lot of our friends avoiding cases of fevers. This is the book that I am going to write, and I am writing about how to manage fevers in our clinical practice. But something in brief I would like to tell you with some cases, that how do we approach a case of fever. Basically, it is your thinking process in each fever that helps us to come to a remedy. Then the clinical management, the doses, that comes much later. But to understand the fever and the patient in the fever has a process, as a pattern. That is what we will discuss now. So we'll just go towards some PowerPoints, how I think in cases of fever, and then we'll come back to cases. Over to the PowerPoint. So how to think in case of fever. There are some important points that we need to remember while doing case taking in fevers. Apart from whatever we have discussed earlier, when you know that it is an obvious case of fever, there are few things that I generally tend to observe. The first, is the child or the person active or dull? Is he restless physically or mentally? Is the child playful or has been in the mother's lap? There is another important state which generally a patient comes with, that's what we call as torpor. I can demonstrate this state with some of the cases, but it is that state of non-responsiveness which is slightly more severe than the sleep, but more due to toxicity of the fever rather than the sleep which comes on its own accord of exertion and rest. These are the first things that we need to observe. Then what we try to see is if there is an obvious discoloration anywhere. Many a times in viral fevers there are discoloration of redness, some eruptions, some boils that come up. Then some secretions like lacrimation, which is very commonly known to have lacrimation in patients with fever. Some patients perspire in fever. Some patients have redness of the parts in fever. This is what we need to observe first. Once that is over, you see what is the general behavioral pattern of the person in fever. Now, whatever I am telling you to observe is most important that you observe when the patient is having fever. Many a times it so happens that the patient is brought to you when the fever is subsided. And when you are seeing the patient is at his best and the patient's relative or the patient is relating his symptoms not in fever but otherwise. Any symptom that is taken when the patient is not in fever, it does not help us to come to the remedy at all. So whatever cases that you see, you either call them when they have fever or you take the totality or the symptoms only when the patient is having fever and not after fever. Now, when you are taking the history, as I mentioned earlier, the causative factor is most important. What is causative factor? What is something that happened immediately which resulted into fever? Now, it can be an exposure to cold or it can be anything, an infection, but it is very important to note that it is not always that the causative factor determines the remedy, but it always determines the change that had occurred in the patient after the cause. Then the next important thing that we know is the fever chronic, long standing, or it is very acute. Acute fever is something which comes immediately after an exposure to a particular thing and chronic fevers are those fever has been there for many years, many months or many days, and in these cases the history pattern will be slightly different to than in an acute case. Once we know the cause, what is the next that we should know? It is not to use the cause isolatedly by taking ailments from getting wet or ailments from change of weather, but the cause and its effect immediately after is to be understood the first. For example, suppose we have causes like maybe getting wet, change of weather, which is so common in children, taking cold food or taking outside food which is rich and fatty, after vaccinations, after emotions, after infections, etc. Once we know this cause, the next effect that we see is what is the change that has occurred in the person. Whenever I am looking at a cause and effect, and especially acute cases, I always see what is the cause and what is the physiological change. Like when I am dealing with pathological cases, I would always see the cause and the pathological change. But if it is an acute phenomena, the first thing that changes is the physiology. So, the physiological effect can be a dryness of a mucous membrane, an increased secretion, an articular inflammation, a myalgia, a serious inflammation of a joint or a organ involvement, etc. Once I ascertain what is the effect or the change in physiology, then I know which are the remedies that has this in its domain. Here we can quote Dr. Burt, who has written the book Physiological Materia Medica, and after reading that, a lot of my conviction became so strong that I generally make it a point that I see the physiological change every time. What Dr. Burt writes: a special study of physiological action of each drug has to be made, for drug pathology is quite as necessary to the scientific physician as disease pathology. And a physician who cannot diagnose the pathology of the drug need not expect to be successful in treating the disease. We are fully persuaded that to endure the crucial test of science, the materia medica of the future must stand upon a physiological base. And it's really true. When we are treating infections, when we are treating higher end pathologies, it is very important that we as homeopath understand even the physiology and the pathological change that occurs after the infection or after the cause. Once we register this, we start to look at something which is very peculiar in the case. The peculiar symptom can be a characteristic symptom or a pattern or any concomitant or anything in the case. So, now onwards, all those approaches which I have told you earlier have to be used together to understand what is there in the case. So, if it is a fever, then you see if the fever has a pattern. Does it come as a heat, chill, sweat, or it comes with some associated symptom in each stage? I firmly believe that each stage of fever has to be dealt in depth. For example, if it is a chill stage, you understand the chill stage completely. If it is a heat stage, you understand the heat stage completely. In the sense, what is the concomitants in heat, what are the things that follow before the heat stage, what are the things that come during the heat stage, same way in the chill stage and same way in the sweat stage. And many a times, lot of peculiarities can individualize the patient at the understanding of the stage. The important another symptom that comes during fevers or during case taking of fevers is what happens prior to the fever and what happens after the fever, like, and which can be a concomitant or which can be an associated symptom but which happens as an habit. Okay, so these are another important aspects which we can see in cases ahead, but this is something that we always keep in mind, what happens as a pattern in fever. Dr. Allen writes, the symptoms occurring before and during the chill, heat, sweat, and even the pyrexia, the symptoms of occurrence of the paroxysms, the parts of the body in which the chill first makes its appearance, the regularity of its stages, the degree of absence of thirst and the time of its appearance, as well as the constitutional ailments aroused by the fever are to be carefully noted. Now, what Dr. Allen means to say here, that each and every stage has to be understood fairly well, and even the stage of apyrexia, that is the stage when the patient is not having fever. Second thing is, if the stage has a pattern, is it coming at every 3 o'clock? Is it coming only in the evenings? Is it coming only at a particular time after a particular change in temperature? Again, what is the thing that arouses in the constitution after the fever comes in? These things have to be carefully noted. Where the chill begins in. If the chill begins in the feet, the remedies are different. If the chill begins on the head, the remedies are different. If the heat begins in the lower extremities, the remedies are different. So you can individualize the patient even at the point at which the chill begins. I still remember one fantastic case which I had. It is not about fever but about a pattern which she was explaining to me about. She was a full-blown case of rheumatoid arthritis. All her joints were swollen. She could barely walk when she came to the clinic. When I saw her, her fingers, the smallest joints, they were swollen. She could hardly move with the pain. And I asked her how this whole problem started. She says that it is there since long time, and every time she gets a fever, the problem increases. So I asked her, come on, describe me the fever. And she says the fever is always accompanied with chills. And then the fever comes. I said, okay, tell me more about this. And she says, for me, the chills always begins on the lips. And it is for me that the lip starts to shiver first. And she goes like that. Because of this, then the whole body gets into a chill stage and then the fever starts. Now this was a very important and a peculiar symptom that I found. When she was relating her complaints, I was already searching for this as a symptom. I anchored at this, and luckily I found a remedy which was the only remedy indicated. Now the questions ahead and the corroborated evidence that she gave, that she had dryness of mucous membranes, she was extremely constipated. Her joint pains were so severe that she had to tie bandages to keep herself to normalcy. She was extremely thirsty, and the remedy was bryonia. Chills begins in the lips, the only remedy is bryonia. After knowing this and corroborating with the case and the generals, the bryonia was given at a dose of 200, which was later repeated when she had an exacerbation, but it solved the case completely forever. Why I mentioned you this example is, where the chill begins itself can be an entry point to the case. As we explained earlier, concomitants are something that we need to look for. Patients will not tell the concomitants when they are in fever or in problems, because they are not in tune to the symptoms, or they are so much tuned to the symptoms that they don't believe that it is a peculiar finding. Now, where to look for the concomitants? It can be a pain, it can be a sensation, it can be a diarrhea, it can be a color of the stool, it can be a palpitation, it can be a chest symptom which is associated with a stomach symptom during that time, it can be a throat pain, it can be a hoarseness of voice, it can be a color of the tongue, it can be a cough during fever. So all these systems, whenever they are expressing symptoms at the onset of fever or at the onset of chill, becomes important. So what I mean to say is, the concomitants are the symptoms that we need to inquire for, and when it comes in the most uncompensated way, note it down to understand the person further. Similarly, in stomach, you can see for the appetite, the thirst, the vomiting, in ears, the pains, the tinnitus, the discharges. In physical generals, if there is a trembling, weakness, vertigo during fever. In extremities, if there is numbness, cramps. In eyes, lacrimation, discoloration, sensation or swelling during fever. If there is any alternating symptom that happens, there is a peculiar perspiration that happens during fever or during chills, any particular position that the patient adopts during fever, any urinary symptoms during fever, any mental abnormalities like loquacity, anger, fears or dreams during fever. This will help us to understand the concomitants. Now we go to the next important thing is the modalities. What are the modalities that we look for? The general modalities and the peculiar modalities. Like the way we discussed earlier, it can be a general modality of the change in the weather that aggravates and general modality of covering that ameliorates him, or a local modality like wanting the feet to be covered or wanting a particular part of his face to be covered. This can also indicate a indication to the remedy. Clinical examination. Clinical examination is something that you never miss in a case. You always see the patient from top to bottom, see for the thermals, which part is hot and cold, see the tongue, the systemic findings, and on examination, if there is any organomegaly. If you find a patient has a toxic look, see for the pulse and the proportion of the pulse to the temperature. So, after evaluating the patient in all these aspects, the clinical examination, the concomitants, the modalities, the pattern of fever, then when you put the symptoms in order of predominance, you repertorize and see which are the remedies that are coming. The remedies that you need to come for differential diagnosis should have a physiological correlation to the patient, and the remedy has to match the physiological relation to the case. If this matches, then the remedy works for sure. Now, this is in short that I have discussed about fevers. So, what I spoke to you is a very general approach in fevers. Still to this is a detailed approach in cases of fevers. For example, in cases of intermittent fevers, in cases of infective fevers like dengue, malaria, or fevers due to some pathological infections, in fevers of due to a pathological condition, a patient is having a systemic disease and he flares up with a fever, or in pyrexia of unknown origin, the patient is having fever for months together and it's not responding. Each of these patterns have an approach and a kind of understanding that a doctor should know when he's treating this. This can be dealt in detail later. After this, we go to the cases in fevers where we have found remedies on the different approaches that we have learned now. The case which I am going to now show to you is about a fever which I later diagnosed as dengue. A 17-18-year-old girl comes to me in a state of fever. When she comes, she immediately goes and lies down on the bed because she is hardly able to sit, and she is extremely weak, prostrated, very different look on her face. So I ask her to tell me about her problem. Now, when you are playing the video, the most important thing that you try to understand is the look of the person. This look is not of a fever which is due to some allergy or plain inflammation, but it is a look of a person who is having a toxicity inside, a toxic look that we call. So we catch on with the video of the case. काय काय होतंय? आणि अजून अजून कुठे दुखते? अजून
असं झोपलं दुखतं, अशी अशी नाहीतर उलटी झोपू शकते.
अजून अजून काय होतंय? भूक नाही लागत. अजून उठवत नाही का उठावं असं वाटत नाही? उठायला होत नाही. अजून कशी आहे ही ताप आल्यापासून?
एकदम डल आहे.
डल
म्हणजे झोपूनच राहते. तापामध्ये तर तिला 2-3 ब्लँकेट चादर बिदर घालून तरी पण अशी उडते, अशी हळूहळू करते आतमध्ये. सगळं फॅन बंद कर, सगळं बंद कर सांगते.
कणते? बडबडते?
नाही, बडबडत नाही.
ग्लानीत असते?
हां, ग्लानीत असते.
ग्लानी म्हणजे?
त्याचं विचारलं तरी पण असं एवढं पटकन यायचं उत्तर देत नाही.
म्हणजे जरा परत सांगा. विचारलं
आता विचारलं काय पाहिजे, म्हणजे काय पाणी पाहिजे का असं वगैरे, असं म्हणजे पटकन असं उत्तर देत नाही.
मग कधी उत्तर देते?
थोड्या वेळ देते.
म्हणजे पूर्ण वाक्यात सांगते का नुसतं हो नाही सांगते?
हां, हो नाही सांगते.
आईच पाहिजे बाजून
आई पाहिजे बाजूला.
काय करायचं?
असं धरून राहा म्हणते, पकडून राहा.
डोकं दुखतं? पहिले अश्विनी लेट मी शो मी दॅट स्पॉट.
कुठे लागलं ते दाखव.
तेल पण आहे इथेच ना? इथे? हां? आता नेक्स्ट रिपीट करायला येतो. सेम थिंग. तुला बसता नाही ना? मांडीवरून असं स्ट्रेट बसलीस तर तो हात टच झाला की दुखल्यानंतर काय दाखवलं?
हात धरून उठवून बसावं लागतं.
नहीं, he was very punctual. Morning 9 o'clock or 9:30.
हात धरून उठून बसायला लागतं म्हणजे काय?
असे स्वतःहून होते.
नाही उठत? ते कधीपासून आहे?
ते पडलं.
त्याला असं असं. अजून अजून अजून
सांग.
अजून काय बदल आढळला आहे?
म्हणजे झोपल्यानंतर म्हणजे अशी झोपते ना, छातीत कसं तरी होतं, मग वर येते असं.
आणि
मग उठल्यावरती लगेच ढेकर येतात. असं वाटतं उलटी होते, पण मग उठली की फक्त ढेकर येतात बस.
अजून काय करायचं वाटतं जर अजून त्रास करायचा असेल?
झोपून जायचं.
Now look at the face of this girl. This face is something which I feel that we should always keep in our mind. This is the face of a person who's having an infective process inside. The toxic look, the sunken eyes, the dark circles around the eyes, the dazed eyelids, the ruffled hairs. These kind of looks are generally in patients who are toxically affected. And in such cases, it is very important that you investigate the patient on the first go itself. Seeing this, I asked the patient to be investigated. And once the investigation was asked for, the patient had come for a follow-up. The investigation showed a total WBC count, that is the leukocyte count, as 3200, and then we asked for a dengue, and dengue test was positive in IgG IgM. Both were positive. This is a case which requires admission. Okay. Now watch further. झोप लागते. अजून काय सांगायचं तुला आता या त्रासाबद्दल? तहान कशी आहे? भूक नाही लागत? अरे तहान तहान.
मॉर्निंग में क्या था बच्चे?
तर सांग, तापात दात कुडकुडतात का थंडीत कुडकुडतात? थंडीमध्ये नक्की ना?
दोनों में से 4 गोली
पांगवून लागतात ना?
हो